Acute osteomyelitis is an emergency in orthopedics practice, and if this patient going to miss by our resident, that can cause a devastating problem as well as endanger that child life, as well as they can uh, mm, the sufferer for the all sequelae due to this acute osteomyelitis. The acute osteomyelitis, mainly a disease of child, occurs after an episodic bacteremia and followed by a trivial trauma, may be causing from a small hematoma or fluid collection around the bone and soft tissue. And most common causative organism in child as well as in adult also is Staphylococcus aureus. 70% cases in randomized control trial we can see causative organism is Staphylococcus aureus. Now, why it is so important? I put this PPT for this because when we get the radiological sign of acute osteomyelitis, then we miss the bus already. That means clinical radiological suspicion or clinical suspicion of acute osteomyelitis is very important, because we can save that life of the child, we can save the complication of the child, we can save the limb problem of the child, and in the long term we can avoid multiple surgical option to manage the complications. Okay, the most common radiological finding or first radiological finding in acute osteomyelitis is periosteal reaction and soft tissue shadow. For getting this periosteal reaction and soft tissue shadow, at least 7 to 10 days is minimum uh, delay for getting this type of radiological finding from the onset of acute osteomyelitis. Now you can easily understand, for these 7 to 10 days patient can die in sepsis, patient can present with a pathological fracture, patient can complain with a septic arthritis, which is the most common and dreaded complication of acute osteomyelitis. And along with to see the loss of corticomedullary differentiation, which is another point in favor of osteomyelitis, that change need at least 2 to 3 at least 2 weeks, otherwise we cannot understand. So most common radiological investigation done is x-ray. So we have to judge this osteomyelitis patient very early by our clinical eye. Now mainly the susceptible group of this chronic osteomyelitis is acute osteomyelitis is malnutrition. In for adult patient, renal failure and hepatic failure, diabetes, autoimmune disease, and patient suffering from malignancy and immunosuppressed patient, or very old age patient or young child, small pediatric age group, and smoking also a risk factor. And the most common positive organism for this pathogenesis of the osteomyelitis is Staphylococcus aureus. And why Staphylococcus aureus? Because the presence of surface antigen play a key role in bacterial adherence to the type 1 collagen, which is the maximum collagen in the bone matrix, and endotoxin that suppress the local immunity response. And the glycocalyx may form around the bacteria, can cause biofilm and enhance the adherence to the other bacteria, and along with some inert metallic implant. So it can be a toxic source of the bacteria, and it can help for colonization of the bacteria and proliferation of the infection. Now, the bacteremia is a common event in a pediatric age group, and as a consequences of other infections such as otitis media, pharyngitis, sinusitis, it presumes that the bacteria gain access in the metaphyseal location via nutrient artery. Now what happened? In this metaphyseal region there is hairpin like bent vessels, increased vascularity causing pooling of blood, also called as lack of blood, or lack of blood means a pool of blood and stagnant blood, and there is a immature cell in metaphysis due to high cell turnover. I already discussed it in our previous classes. Due to the presence of physis and relative lack of phagocytosis over this area, and presence of degenerative cartilage cell and end arteries in the metaphyseal region, and this area is more prone to trauma and acute hematoma formation, and it has a single endothelial lining in the metaphyseal artery. So all are these pathognomonic and or are the etiology for why this area is more susceptible for bacterial infection or colonization. Now after infection embolus enter in the nutrient artery that trapped in the vessels in the small vertebrae, then it can block the vessel, the area of the bone become necrotic. Now due to active hyperemia in the vicinity with infiltration of polymorphic nucleus which will produce a exudate. Now this can cause increase the pressure over this area, and it can cause excess exudate and debris, and which can cause the acute pain over this infected bone. So this is an explanation, whole explanation for why this is called in the metaphyseal cause in mesothelial region and why the pain is occur, and it also will give the explanation of periosteal reaction. I will discuss it now. Due to vessel compression there is a further necrosis occur. Exudate follow the path, at least the least resistant pathway, then it gets accumulate in the subperiosteal space and form the abscess and drain in the blood supply, and it can perforate to spread to the soft tissue. Now due to this type of spreading there will be a insult to the periosteum. Due to this periosteum insult, I already told, due to hyperactivation of the cambium layer it will cause periosteal reaction and soft tissue shadow. Why? Because the infiltration of the soft tissue through the least resistant pathway. So this is an explanation why within 7 to 10 days there will be periosteal reaction, soft tissue shadow, and due to this exudate and foci there will be loss of corticomedullary differentiation also. Okay. Now the clinical feature. Generally the child who is suffering from acute osteomyelitis used to get most commonly predisposed from predisposing factor is failure to thrive, and there will be a pseudo paralysis. What do you mean pseudo paralysis? Patient will not move that affected limb, and there will be grade 4 tenderness, means patient will cry when you try to touch that area. Okay, so this is called grade 4 tenderness. Without touching that they will cry, and patient will give you hectic rise of temperature, fever, and in local examination we can see the local redness, swelling, arm and edema, and restricted joint movement, and metaphyseal huge tenderness. And before diagnosis radiologically and confirmatory, we can see the child face. They will be must ill looking, increased temperature and pulse, limb will be held in the pseudo paralysis position, along with all the problem I already discussed. Along there may be edema and lymphadenopathy also. Reactive lymphadenopathy may be found in the angular region, or for upper limb there will be the axillary and cervical lymph node. So there is a chance of clinical diagnosis, and that will think on that line, that that child may be suffering from acute osteomyelitis if this look is associated with this all the finding. Now there is a huge line of investigation. See, the investigation is the definite in sources for identification the disease, but I again tell the clinical assessment of that patient and will do your maximum diagnosis. After that we can go for blood culture, even bone scan, x-ray, full blood count, CRP count, ESR will be high, and we can do MRI. MRI is very fruitful investigation to know the extent of the disease and to exclude it from other same uh, clinical presentation of other disease. I will discuss it immediately. And we can send blood culture also. Okay, and after any invasive procedure, what we can do a ultrasound. uh, it will help, and some bone liquor scan is also help. Well, but in my point of view, to do any before doing any intervention procedure for a child, we can go for non-invasive procedure, that will be better. And as we are very much blessed with this MRI, we can exclude other disease, like most common chance of this type of acute osteomyelitis presentation is rheumatic fever, multiple joint pain, swelling, Ewing sarcoma, which is radiologically similar like onion peel appearance and loss of cortical medicines and high rise of temperature, fever, swelling, and may be found in the diaphyseal metaphyseal lesion. But MRI can diagnose the intermediary extension and type and which help to differentiate it from the a malignant bone tumor. Okay, and sometimes we can see there is a chance of cellulitis also, there is a chance of acute suppurative arthritis also, and there is also eryplasia, raised red margin also. It is also only a superficial infection, but most dreaded diagnosis, differential diagnosis is Ewing sarcoma, and most common diagnosis is cellulitis, differential diagnosis, and rheumatic fever, joint pain. Now, after all this clinical radiological assessment, we have to prevent mainly the complication, immediate and delay. What are the immediate complication? Immediate complication, it can cause septic arthritis. What do you mean by septic arthritis? Septic arthritis is a type of infection of the joint, and it characteristic by swelling, inability to move the joint, huge hectic rise of temperature, pus in suppurative pus over the joint, and destruction of the articular cartilage, synovium, and it can cause if it is untreated, it can cause bacteremia and it cause sepsis, multi-organ failure even. And in the pediatric age group, this septic arthritis is more common. Why? Because this atypical presentation of the physis, because some physis is anatomically will intracapsular and intersynovial also, and for this region any thrombus or any bacterial infection easily can transfer into the joint. So the chance of septic arthritis is very high, and it can cause weakening of the bone, so pathological fracture is a chance. And as a sequelae of this infection, it can cause a chronic osteomyelitis, and in the long run this septic arthritis can cause joint if patient have saved from this acute condition, this septic arthritis can sequelae, in case of pyogenic septic arthritis, sequelae bony uh, ankylosis, and most bad and most common complaint of septic arthritis is stiff knee or stiff elbow or stiff joint. It is very difficult to manage because all around the soft tissue will very unhealthy, and it needs multiple draining and multiple operation. As a result, the wasting of the muscle around and the joint structure stiffness is very difficult to manage. So to prevent this complication, we have to know the proper treatment protocol. And along with this septic arthritis, there is a chance of psoas abscess also. But psoas abscess not solely come from the acute osteomyelitis. It can be from any vertebral osteomyelitis or any chance of pots spine, etc. But psoas abscess is an a abscess over the psoas muscle, usually due to disease of the lumbar vertebra and the pus descending from the muscle pain. Atypical symptoms like low back pain, pyrexia of unknown origin, groin pain mimicking the septic hip, and frequent micturition, lump in the abdomen or in the flank, or it can think about the psoas abscess. Now, tuberculosis and staphylococcus is the most common cause of psoas abscess. And drainage and proper antibiotic coverage is the treatment of choice for the psoas abscess. See, this is the psoas muscle taking origin from the lumbar vertebra, and then it will go through this iliopsoas, and it will join the lesser trochanter. Now, this fascia covering the psoas muscle is the main home for psoas abscess, and it can trickle down under the inguinal ligament, and it can come to the scarpa triangle or femoral triangle. Now, the drainage, before going to drainage, you have to know some anatomy. From the lateral view, this is the iliac crest, and on the posterior aspect of the iliac crest, there is the electrospinae muscle and operator externus, and there is a anatomical weak portion, is called petit triangle. From this petit triangle, there is a chance of lumbar hernia, but this is the window, or this is the gateway for drainage of this psoas abscess safely. There is no vascular structure here, and no important neurological damage can be occurred for to this and this approach. We can put a incision over just above the iliac crest. We can put a artery, and we can remove the all this pus, and we can wash it with NS, and we have to break all the loculi, and we have to, as per the operative principle of abscess drainage, and we must put a drain, and we must send this pus for bacterial culture, TB culture, pus culture, along with the gum stain and culture sensitivity test. Okay, but some expert surgeon can do the drainage from this femoral triangle also, but there is a chance of vessel injury, nerve injury, so be careful, and incision will be done by expert surgeon. But for draining this abscess from the petit triangle, it need no such expertization. Just diagnose it by clinically, and patient may suffer from free space deformity due to spasm and abdominal swelling, hectic rise of temperature, and it may be mimic with the septic arthritis of hip, and MRI will give you the idea, and X-ray will give you just a soft tissue shadow, but MRI will give you the definite diagnosis of this psoas abscess. After that, we will put our knife before going in details, just I utter again petit triangle. This is very important topic for general surgery and with orthopedic surgery. Now, treatment of osteomyelitis. Maximum treatment of osteomyelitis, we used to get that patient in a septic shock, or we in our tertiary center may patient come with pathological fracture or any complication. So in to prevent the earliest or the dreaded complication of acute septic arthritis is to prevent septic shock. Now, to prevent septic shock, what we will do first, we have to take care of the pain of the patient, and we have to take care the dehydration of the patient, and we have to take decrease the bacterial load. How you do that? First, we have to do some splintage. We have to take the blood along with this this IV challenge. We will put the IV fluid along with empirical antibiotic like ceftriaxone. Now we will put the patient for urgent operation, because this is an emergency. We cannot wait, because if we going to wait, it can cause septic shock, it can cause joint destruction, or it can endanger the life of the patient, not only the limb. So analgesic, splintage, and IV fluid. For limb, for lower limb, we can apply a slab, or we can apply a Thomas pin. For upper limb, we can apply a arm pouch bag. Now, antibiotic and we must send the drainage or the material for both gum staining and TB. Along with, we must send the biopsy from the bone for exclude the chance of Ewing's sarcoma. But before putting any knife, and we have to judge that patient clinically. Ewing sarcoma patient will not present in such fulminant presentation, which is more obvious in septic arthritis of hip, or septic knee, or acute osteomyelitis. It you have to judge it properly. But as a routine protocol, you must send biopsy also. And what we will do for surgical debridement, we will just open this area and we will remove the pus, and after that you have to do multiple drilling of that bone, that I already told, and the pus will will be in the deeper part of the metaphysal region. So if we put some drilling, this the drainage of this pus will be very easy. And after one source of this drainage, all the infection gradually peel off due to huge blood flow. Okay, and you have to take care of the general condition like anemia. You have to correct the blood, the other like albumin. You have to take care, and you have to supplement of multivitamin also. Now there is a special special worry regarding how many days you will put the antibiotic. As per normal norms, 6 weeks is the minimum time duration for giving IV antibiotic in case of if patient is suffering from acute osteomyelitis, because for first 2 to 3 days until unless the report is coming, you can start with amoxicillin, or you can start with ceftriaxone also. But amoxicillin is the first drug of choice for the growing child. Okay, so this is the multiple drilling of the cortex, and we can do it by only hand drill. Okay, so I think the last word of this this operation, after this draining and after multiple you must put a drain. For old age, we used to give a corrugated rubber drain. Corrugated rubber drain actually a dependent drain. Same here in the swash after drainage, we used to give a drain. If as per the rule of drain, it must put in the dependent aspect, but nowadays we are able to use the negative suction drain. So um, that is very advantageous, and the drain must not for both septic arthritis and and for osteomyelitis we must not remove the drain at least 5 days, and we have to check the drain material. If the drain material is less than 10 ml for after the fifth days of the index surgery, for whole day less than 10 ml, then it we can remove this drain, but not before at least 3 to 5 days of initial surgery. We should not remove the drain because it can cause reaccumulation of this exudate, and it can cause again this type of problem, especially in case of septic arthritis and acute osteomyelitis. Okay, I think I can cover all in details for the management and diagnosis of acute osteomyelitis.